هنبتدي السيشن بتاعت brachytherapy multidisciplinary management of cervical cancer focused on 3D adaptive brachytherapy. أنا بس قبل ما نبتدي أنا برحب بكم بجميع الحاضرين في المؤتمر القسم العاشر لقسم علاج الأورام بكلية طب عين شمس، وإحنا سعداء بوجودكم معنا. وتحية خاصة مني بما إن الجلسة دي عن البراكيثيرابي لتيم البراكيثيرابي اللي موجود عندنا في القسم في جامعة عين شمس. الحمد لله التيم ده بقالنا حوالي دلوقتي سنتين. قعدنا سنة في مرحلة تجريبية كده، وبعدين سنة اشتغلنا يعني as full professional. طبعا التيم بيتكون من يعني مني ومن بالترتيب السينيورتي كالأطباء دكتورة غادة، دكتورة كريستين، دكتور محمد درويش، ودكتورة هدى، وكان معانا دكتور محمد هيبة، وهو الحمد لله هو سافر دلوقتي لإنجلترا، بيشتغل هناك، ربنا يوفقه بإذن الله. وطبعا أخص كمان بالشكر نص التيم وهو قسم الفيزياء اللي عاملين معانا مجهود جامد جدا، بداية من دكتورة سمية وفيزيائيين نهى، أحمد، عمرو، سارة، مين تاني حد، أسماء، محمد رفعت الجديد معانا، و اسمها ايه، يوم المشهورة بسعدية، وطبعا جميع الفنيين والتمريض اللي معانا بقيادة هدى. كان لازم اشكر الناس دول، ان الناس دي تعبت قوي معانا في فترة السنة اللي فاتت، فده شكر واجب ليهم، وربنا يوفقنا جميعا ان شاء الله، ويجعل نتائجنا باذن الله مبشرة طول الوقت. نبتدي بقى السيشن بتاعتنا. هو اول حاجة مالتي موداليتي ايميجينج ان سيرفايكال كانسر، اللي هي الدكتورة اسماء مجدي فروم ايجيبت. اتفضل يا فندم. انا عايش، انا بتكلم بالعربي، ان مفيش اجانب اعتقد، ولا في اجانب؟ مفيش اجانب.
Thank you for هم هيبقوا شايفين الاول اللي انا بشوفه ده. Thank you for the organizers and Dr. Ghaida for the kind invitation, for the chairpersons and the attendee for their time. I'm going to talk about the multi-imaging modalities of cancer cervix. I'm Dr. Asma Magdi, Associate Professor at Ain Shams University. First, I'd like our introduction presentation. Okay. I'm going to talk small introduction, FIGO staging, different imaging modalities, ultrasound, CT, MRI, PET-CT, and PET-MRI, and then conclusion. Cervical cancer is the fourth most common cancer among women, representing 6.6% of all cancers in female patients. The most important predisposing factors for cervical cancer are human papillomavirus, immunodeficiency, HIV, smoking, socioeconomic factors, lower income levels with less access to screening tests, and human papillomavirus vaccination, and then family history. The prognosis is based on the stage, size, and histologic grade of the primary tumor and the status of lymph nodes. Assessment of the stage of disease is important in determining whether the patient benefits from surgery or will receive radiation therapy. The primary treatment for advanced cervical cancer stage more than 1P is chemoradiotherapy, followed by brachytherapy. The risk factors in cervical cancer to assess on imaging are tumor size, invasion into parametrium, extension to pelvic side wall, vagina, bladder, or rectum, lymph node involvement. Imaging has gained importance in recent years for initial staging, treatment monitoring, and follow-up of cervical cancer. The FIGO staging system is a system fundamental for planning treatment strategies and prognostic classification of patients with cervical cancer. In stage 1, the carcinoma is confined to the cervix. In stage 1B, is categorized recently into 1P1 with tumor less than 2 centimeters. Sorry. Stage 1B2, carcinoma more than 2 centimeters and less than 4 centimeters. And stage 1B3, invasive carcinoma more than 4 centimeters, because the size is very important in prognosis and also in fertility preserving surgeries. Stage 2, the carcinoma is beyond the uterus, but doesn't extend to the lower third of the vagina. In stage 3, in stage 3, the carcinoma involves the lower third of vagina and extends to the pelvic side wall or involvement of the pelvic or para-aortic lymph nodes, with stage 3C is newly developed in the FIGO 2018. بيقعد يسمط لوحده السلايدز.
لا احنا ما نجيش جنب اي حاجه تبذير لو ده مضايقك
متضايقه من ده. مش عاوزاه ده.
اللي بيحصل
بتمشي لوحدها السلايدز. اوكي. Stage 4, the carcinoma extended beyond the pelvis to the bladder and rectum. Clinical staging is suboptimal for certain tumor characteristics such as size, parametrial invasion, and lymph node involvement. In patients with early stage cervical cancer, stage 1A and part of 1P1, the microinvasion is only detectable using tissue evaluation. The rest of the tumor stages, including local extension, can be assessed using imaging modalities such as CT, MRI, PET-CT, which have higher sensitivity and comparable specificity to the clinical evaluation. The National Comprehensive Cancer Network 2022 practice guidelines in oncology recommended CT or PET-CT for tumor surveillance and follow-up, and MRI for the local assessment of the stage more than 1P1. Staging is essential to predict survival, and surgical planning is considered. Standard management of early stage less than 2A cervical cancers. Nijian et al. Compared PET-CT and PET-MRI and found that both modalities could identify all the primary and metastatic lesions and could strongly correlate standardized uptake value. Tumor staging and the treatment is according to size. Cancers less than 4 centimeters go to upfront surgery. Cancers more than 4 centimeters or advanced stages from 2B to 4A receive the concurrent chemoradiotherapy. The imaging modalities for cervical cancer start with ultrasound, because ultrasound is used to detect the cervical cancer. It is the first modality worldwide because it is widely accessible and affordable. On ultrasound, cervical cancer generally is depicted as hypoechoic mass with increased vascularity, as we see here in this picture. However, tumor echogenicity may vary by histological subtype and can sometimes present as isoechoic or hypoechoic lesion, as we see in this image. Ultrasound, a number of recent studies have reported that ultrasound has accuracy comparable to that of MRI for detection of pelvic side wall extension and parametrial involvement. However, operator dependency and, more importantly, limitation of ultrasound in the detection of lymph node status because of its small field of view hamper its use for staging of cervical cancer. Regarding CT, the poor soft tissue contrast of CT is a limitation for local evaluation of cervical cancer. Approximately 50% of cervical cancers are isodense to the adjacent stroma and cannot be delineated on CT. For cases in which a tumor can be seen, it usually appears as ill-defined hypodense lesion within the cervix, as we see in this image. Another limitation of CT is low sensitivity for small tumors. Overall accuracy of CT for cervical cancer staging varies between 32 and 80%. For prediction of early parametrial invasion, the accuracy of CT is lower than that of MRI at 55%. For lymph nodes, CT evaluation relies on size, with a cutoff value ranging from 0.8 to 1 centimeter in short axis, or the presence of heterogeneity or necrosis with performance similar to MRI, but inferior to PET-CT. CT is useful in staging advanced disease, as we see in this image. The cancer is invading the side walls and the rectum. Distant metastases are seen with primary or recurrent disease and can involve the liver, lung, and bone. Regarding MRI, the high soft tissue contrast resolution of MRI makes it the preferred modality in local staging of cervical cancer. The main rule of pelvic MRI is assessing, as we said before, tumor size, parametrial involvement, pelvic side wall extension, and the invasion of adjacent organs like bladder and rectum. In multi-center studies, Zhang et al. Found that overall accuracy of staging increased from 61 to 81% after combination of clinical finding with MRI. The tumor, as we see here, is seen in T2 weighted image without fat suppression. It appears as intermediate signal intensity. As we see here, it causes obstruction of the cervical canal with retention of endometrial secretions. There is no parametrial invasion in this case. The use of intravenous contrast material in evaluation of cervical cancer is controversial. Many authors don't recommend routine administration of IV contrast material for staging protocols, given the various degrees of enhancement of cervical tumors. However, dynamic contrast enhanced MRI is reported to be of value for small lesions in patients post-cervical cancer treatment, for surgical planning in patients who wish to undergo fertility-sparing surgery, and for distinguishing between cervical and endometrial tumor when the primary tumor is locally extensive. Dynamic contrast MRI is in combination with diffusion improves the identification of residual and versus recurrent tumor compared to post-radiotherapy changes. The parametrium. As we see here, it is a normal parametrium with fat and the connective tissues that surround the uterine corpus is free. Also in this cancer, as we said before, the fat and the connective tissues that surround the uterine corpus and cervix is free, and the low signal intensity around the cervical stroma is preserved. So here the cancer cervix show no parametrial invasion. Parametrial invasion is disruption of the stromal ring, obliteration of the periuterine fat planes, encasement of the ureters, and the involvement of periuterine vasculature are signs consistent with parametrial invasion. As we see in this case, the disruption of the cervical stromal ring and the tumor is seen extended on the left side, causing diffusion restriction in the diffusion weighted images. Parametrial invasion, although MRI has a high negative predictive value, 94 to 100% for parametrial invasion, reported sensitivities vary between 38 and 100%. Addition of diffusion sequences has complementary value for evaluation of parametrial involvement, increasing sensitivity and specificity 82% and 97% respectively, compared with MRI without diffusion. The pelvic side walls, as we see here, the obturator internus muscle, the piriformis muscle here, and the obturator internus muscle, and the levator ini muscles are normally seen. Pelvic side wall invasion has been described as tumor that is less than 3 millimeters from the pelvic muscles and vasculature. Gross invasion is easier to recognize and is seen as enlargement of the musculature, encasement or narrowing of the vessels, and versal extension to the pelvic osseous structures. As we see here in this image, the cancer cervix causes a parametrial invasion, and it reaches the levator ini on the left side with distance less than 3 millimeters. Also, it obstructs the lower distal end of the ureter, with causing hydronephrosis proximally. Extension to the vagina. For evaluation of the vaginal involvement in patients with cervical cancer, MRI accuracy is reported as 86-93%. It is seen as replacement of the low signal intensity of the vaginal wall by high signal intensity tumor. Evaluation of vaginal wall integrity may be limited with large exophytic tumors protruding into the vaginal canal, which can usually be improved by use of endovaginal gel. As we see here, normal vagina with anterior and posterior vernix. Here, the vaginal gel is injected. Another case with cancer cervix. Here, the cancer is reaching the upper third of the vagina, and here it reaches the lower third of the vagina. Bladder invasion. Local extension of the tumor to the bladder can be evaluated by using MRI with sensitivity of 83% and specificity of 100%. MRI findings that suggest bladder invasion include nodular and irregular bladder wall tumor protruding into the bladder wall. Presence of vesicovaginal fistula is diagnostic for bladder wall invasion. Rectal invasion by cervical cancer is less prevalent than bladder invasion in patients with stage 4 disease, and carries a worse prognosis, as we see here in this image. The cancer cervix invades the bladder and the rectum posteriorly. Lymph node invasion. MRI findings that predict metastatic involvement of lymph node are larger than 1 centimeter in short axis. Also, the speculated contour and signal intensity similar to the primary tumor and heterogeneity of the internal architecture makes the lymph node suspicious. The use of lymph node diffusion weighted image for lymph node staging has been controversial. Some studies say it is of value and some studies say it is of no value. Indications of MRI. Local staging, pre-treatment in local advanced tumors. Mid-treatment MRI after 5 weeks of concurrent cisplatin chemotherapy with external beam radiation therapy and before intracavitary brachytherapy. It allows brachytherapy dose adjustment in proportion to the residual tumor volume. This increases local tumor control, reduces toxicity, and improves survival. Also, follow-up after completion of chemoradiotherapy and follow-up after surgery. Follow-up after radiotherapy by MRI, the tumor will show decrease in size, reconstitution of the normal low signal intensity of the cervical tumor. The cervical stroma indicates that the tumor have good response. Functional sequences, including diffusion, may be useful tools to differentiate recurrence from treatment response. Residual viable tumor and the tumor recurrence usually show low restriction diffusion with low ADC values. As we see here in this image, the cancer cervix is seen extending to the upper third of the vaginal canal and the anterior rectal wall with parametrial invasion. It shows diffusion restriction. After radiotherapy, there is complete response with the normal mucosa of the cervical, no parametrial invasion, no extension to the rectal wall with no diffusion restriction. Another case with the cervical cancer is reaching the uterine isthmus and infiltrating both vaginal fornices and infiltration of the parametrium with diffusion restriction. The cancer shows a 30% reduction of its size and shows diffusion restriction, so it shows partial response. Another case with cancer cervix is seen with parametrial invasion and extension to the upper 2/3 of the vagina. After radiotherapy in this image, there is no improvement of the size of the tumor or the parametrial invasion. So it is stationary. Another case with the cancer cervix here is reaching the uterus and the upper third of the vagina with parametrial invasion. After radiotherapy, it shows progression with invasion of the bladder and the rectum posteriorly. PET-CT. PET-CT is a non-invasive imaging method combining the morphological finding provided by CT with metabolic information. To acquire this information, the patient is injected with the tracer glucose and log 2-fluoro-2-deoxy-D-glucose that is labeled with a positron emitter. Areas with high uptake correspond to sites with high glucose metabolism, such as inflamed tissue or tumor cells. It is a useful imaging method in the assessment of lymph node and the distant metastasis in patients with local advanced cervical cancer, and for assessing their response to treatment and the disease recurrence. Most cervical tumors are 18 FDG avid, which it takes tracer, so it is active tumor, except for adenocarcinomas, which may reveal low FDG uptake. The maximum standardized uptake value is a quantitative value, is used to assess the activity. As we see here, the tumor in the CT shows high FDG uptake by PET in combined view. Another case with the lymph node in the right para-aortic region takes the tracer. In patients with advanced disease and at presentation, PET-CT has been found to alter management in a significant number of patients. Sistani et al. Reported that the diagnostic sensitivity and specificity of PET-CT to detect residual tumor in patients with local advanced carcinoma were 86% and 95% respectively, while the diagnostic sensitivity and specificity to detect distant metastases were higher, 97% and 99% respectively. Post-treatment FDG PET-CT is usually performed at 3 to 6 months after completion of chemoradiotherapy, and it is a valid prognostic biomarker. No FDG uptake means complete metabolic response. Reduced FDG activity means partial metabolic response. Unchanged or new areas of FDG uptake indicate persistent or progressive disease. Early detection of residual tumor is important to establish immediate curative salvage therapy, such as pelvic exentration or concomitant chemoradiotherapy. As we see here in this initial PET-CT that shows uptake of the cervical mass here and the left pelvic node and right para-aortic node. After therapy, PET-CT revealed uptake de novo in the liver and lung and mediastinal lymph node and left para-aortic lymph nodes. Another case where 47-year-old woman with a stage 2B squamous cancer cervix with bladder involvement. After radiotherapy, it shows decrease in size, but it's still take uptake of SUV max 8.3, and this is partial response. Radiation therapy planning. PET staging altered management either by extension of the radiation field to include the para-aortic area or by a change in the total administered dose to involved nodes in the pelvic area. Nayan et al. Conducted a study to determine whether use of FDG-CT or MRI could obviate surgical staging in radiotherapy planning for patients with locally advanced cervical cancer. Those authors concluded that 91% positive predictive value of PET in detecting pelvic and para-aortic nodes appeared sufficient to obviate lymph node sampling and to extend the radiation field without surgery. However, sampling is still required to exclude small volume disease, and MRI is insufficiently accurate for nodal staging to affect management. As we see here, the gross tumor volume by the red circle to the cancer cervix here, and the green circle for the clinical tumor volume involving bilateral internal iliac nodes and right para-aortic lymph node. PET MRI. The successful integration of PET and MRI enabled tumor evaluation and the staging in a one-stop approach. As we see here, a cancer cervix shows left parametrial invasion, shows diffusion restriction and uptake by FDG. Another case where the cancer cervix here shows parametrial invasion, but only PET images showed small right external iliac and aortocaval and left supraclavicular lymph nodes, which upgrades the stage 2-4B. Also, PET MRI is used in follow-up after radiation therapy and after surgery. As we see here, that this cancer in the cervical vault by MRI shows diffusion restriction, shows enhancement, and shows uptake, which is near the bladder, but not invading the bladder. Research work are made to compare the diagnostic performance of FDG PET MRI versus PET-CT. In local staging, PET MRI is better, but in lymph nodes, they have no superior. PET MRI is not superior to PET-CT in lymph node staging. Another to compare the efficiency of PET MRI and MRI alone, PET MRI is better than MRI alone. Also to identify the role of PET MRI in predicting a tumor treatment response. Follow-up protocols for local advanced cancer cervix for stage 1B3 and patients who require post-operative adjuvant radiation or chemoradiation. A whole body FDG PET-CT usually performed at 3 to 6 months after completion of chemoradiotherapy. For stage 2 and 4A, a whole body PET-CT preferred, or chest pelvic abdomen CT with contrast within 3 to 6 months of completion of therapy. Moreover, MRI with contrast is to be considered 3-6 months after the end of treatment. In all cases, the choice and the addition of imaging techniques should be evaluated based on symptomatology or clinical concern for recurrence, and PET-CT and MRI are considered the techniques of choice. Conclusion, imaging plays a major role in treatment planning and as a prognostic indicator in patients with cervical cancer. Role of MRI is in the initial local staging, response, monitoring, and evaluation of disease recurrence. Whole body FDG, PET-CT, and PET-MRI play an important role in the detection of lymph nodes and distant metastasis. It can also be used in response monitoring and evaluation of disease recurrence. Thank you. I'm sorry for that.
Thank you, Dr. Asma, for your nice presentation. My question for you, it's better to do PET-CT or MRI at time of diagnosis of cancer cervix? Which modality should be started with?
MRI.
MRI?
Local staging, for local staging. If we suspecting lymph node staging, we do PET-CT. PET-CT is better in lymph node.
Okay. Any question from floor?
Any questions?
دكتورة أسماء، عايز أسأل حضرتك الحجم بتاع الليمف نودز اللي تكاركترايز ميتاستاسيس، حضرتك بتاخدي حجم قد إيه وتعتبريه اب نورمال وممكن يكون يعني بوزيتيف ليمف نود؟
بناخد بالشورت اكسس مش اللونج اكسس of the lymph node more than 1 centimeter. It according the level. In the pelvic nodes more than 8 millimeter. In the para-aortic more than 1 centimeter.
طب 6 مللي؟
By MRI, it is not considered a malignant except if it shows cystic degeneration in suspicious criteria. But as we see in this a case that MRI didn't see any lymph nodes, but the PET MRI detected the small lymph nodes, the activity in small lymph nodes.
يمكن في السيرفكس طبعا يفرق شويه، بس يعني في الريكتم مثلا الاسجل كرايتيريا بتعتبر 6 مللي هاي probability of malignancy. فانا كان سؤالي هل ده ابلايد للسيرفكس برضو ولا؟
لا 8 ملم. We consider 8 ملم.
شكرا جزيلا. طب سؤال اخير برضو، الفاليو بتاع الانهانسمنت، يعني هل لازم اعمل رنين بجادولينيوم ولا؟ لان هو معظم الكاركترايزيشن في المالجنسي ما بيعتمدش على الانهانسمنت في السيرفكس يعني.
ايوه لا الديفيوجن احسن من الانهانس.
شكرا.
الانهانسمنت بس بيبان الفاسكولاريتي بتاع السيرفايكال تيومر، فيقول ان في ريسبونس احسن بالراديو ثيرابي لو في سيرفايكال انهانسمنت جامد يعني. ما هو فعلا في مشكله حتى الان يعني موجود. شكرا.
Now we'll go to a short video about عين شمس brachytherapy.
لا خلاص.
دقيقة واحدة.
اتفضل. ماشي. السلام عليكم، أنا محمد درويش، مدرس علاج الأورام في عين شمس. النهارده أنا يعني هبريزنت 2 فيديوز للبراكي ثيرابي عندنا في اليونت بتاعت البراكي ثيرابي. أول فيديو عن الجورني بتاعتنا من أول ما كان عندنا a dream to have a brachytherapy unit، بدل ما كنا بنبعت العيانين طبعا بعد ما يخلصوا الاكسترنال بيم عندنا ويروحوا لحد اماكن بعيده جدا عشان ياخدوا البراكي ثيرابي بتاعتهم. وكانت يعني اكيد كان بعد ما بتخلص الاكسترنال بيم بنعدي حوالي شهر ونص على ما بياخدوا البراكي ثيرابي، فده طبعا كان بيأخر العيانين. كان عندنا دريم ان احنا تو بيلد براكي ثيرابي يونت، والحمد لله الدريم دي ربنا وفقنا و it came true. اول فيديو هيبقى عن الدريم بتاعتنا. تاني فيديو هيبقى عن البروسيجرز نفسها بتاعت البراكي ثيرابي والابليكيتورز اللي احنا بنستخدمها وازاي بنعمل الانسرشن والبلاننج والديلينيشن والبروسيجر من اولها لاخرها ان شاء الله. ابدا خلاص. اوكي. فعلا حاجة تخلي الواحد فعلا يعني براود من اللي احنا كنا بدأنا له ووصلنا لحد دلوقتي. الحمد لله طبعا أولا وأخيرا. دلوقتي الفيديو التاني هيبقى عن البروسيجر بتاع البراكي ثيرابي من أول ما العيان بيبدأ يجي عندنا لحد ما بنخلص البلاننج أبروفل وندي البيشنت السيشن بتاعته. نبدأ. internal beam. How to choose the proper applicator. بعد كده بنروح نبدا البراكيتيتر بتاعتنا. اول حاجه ده الاكزامينشن اندر انستيزيا. دي طبعا كلينيكال دروينجز حقيقيه للعيانين بتوعنا. هنبدا نشوف كل ابلكيتور من الابلكيتورز اللي احنا استخدمناها. اول حاجه والموست يوزد عندنا هم الرينج اند تاندم اللي بيفيت موست اناتومي اوف ذا بيشنتس. ده الاسمبلي بتاعها outside the patient in vitro. وبعد كده هنشوف بقى inside the patient الكاستور intrauterine tandem assembly. نبدا الاول بالدايلاتيشن. هتلاقوا التاندم داخل خارج كده بنعمل بيه دايلاتيشن لحد ما يبقى انسرتد في الاخر. ده الدايلاتيشن. ساعات بنحتاج ان احنا نملى البلادر علشان يرفع اليوترس شويه عن الانتي فيرجن بتاعه لحد ما نعرف ان احنا ننسرت. كده التندم دخل وعلى now for the ring insertion. طبعا everything is under complete sterile conditions. والرينج والتاندم الحقيقه من اسهل الابليكيتورز في الانسرشن بتاعتهم فاحنا بدانا بيه بس. وبعد كده هنبدا نعمل باكينج. بنمارك الابليكيتور على جسم العيان عشان بعد كده لما نيجي نبدا الجلسه ديلينيشن وبلاننج هيبقى ليهم طبعا سيشنز لوحدهم مع الزملاء الافاضل. وبعد كده العينه بتبدا الجلسه. ده بالنسبه للتاندم والرينج. نمبر 2 is the Fletcher. ده الاسمبلي بتاعه اوتسايد ذا بيشنت. بنحط الستوبر الاول في بنقيس بالساوندنج الانترا يوتراين لينث، وبعد كده بنحط الستوبر عند نفس اللينث بتاع الانترا يوتراين ديستنس عشان ما يحصلش اي further introduction او perforation. الجزء الباقي ده المفروض ان هو هيحصل inside the patient، بس احنا بنعمله الاول بره for demonstration. ده الاوفويد اللي على اليمين، وبعد كده الاوفويد اللي على الشمال، وبعد كده بيبدا برضه الباكينج بعدين. وده منظره في الاخر. لايف بقى inside the patient. بنبدا الاول بعد الانسيرشن اوف ذا ستوبر بنبدا نعمل انسيرشن في بتاع الانترايتوراين تاندم كده inserted. حط الجايد، هيدخل وبعد كده بعد insertion of the guide هنسيرت الاوفويد اليمين الاول وبعد كده الشمال. Nicely inserted. هنبدأ نعمل باكينج وبعد كده درينيشن برضه بلاننج هيبقى مع الزملاء ان شاء الله. والعينة تاخد الجلسة. آخر حاجة needles interstitial radiotherapy. الأول بنبريبير البوزيشنز والدايفرجن بتاع النيدلز اللي هنستخدمها على حسب الام ار اي بتاع البيشنت واللوكيشن اوف ذا تيومر، ولو فيها بارامترال انفيجن ولا ما فيهاش. في البيشنت دي احنا we inserted 4 needles. طبعا احنا كده بنقيس اللينث بتاع النيدل اللي we need to insert. بنقيس الاول البيز لاين بتاعنا زي الصوره دي كده اللي هو 16 سم، وبعد كده عايزين ننسرت مثلا 4 سم، بنقسم منهم يبقى احنا هنزق لحد 12 او 13 سم، وبعد كده بنربط الصاموله بتاعتها. نايس انسرتد. هي البيشنت دي كمان كانت تشالنجينج لان العينه دي كانت عامله توتال ابدومينال هيستريكتومي بايلاترال سسبنجو اوفريكتومي قبل كده اللي بناين كوز، وبعد كده حصل لها فاجينال بول كانسر، فما كانش في مكان اصلا ان احنا نحط فيه انترايتوراين تندم، فكان بس ان احنا انسرتد نيدلز اونلي يعني، والعينه خدت الجلسه. very proud. شاء الله الديتيلز بتاعت الديلينيشن اورجانز ات ريسك والديلينيشن بتاع التارجت، وان شاء الله البلان ابروفل والبلاننج هيبقى في السيشنز اللي جايه ان شاء الله. Thank you very much.
Thank you actually to all team. Thank you very much. Actually, I am impressed with your work.
Thank
Very
you.
good.
Thank you very much.
Now we'll go to second session, contouring principle, target volume and organ at risk. الدكتورة غادة رفعت, دكتورة كريستين, and دكتورة هدى الخضر.
Good evening. We will start with target volume delineation. We choose to go through a case. We will present the case and discuss its delineation for the target volume, then organs at risk by Dr. Ghada. So our patient is a 47 years old female patient married with 2 offspring. She has a past history of hepatitis B virus positive. She had postcoital bleeding. She sought medical advice, had examination under anesthesia, which showed the cervical mass with left parametrial infiltration, not reaching lateral pelvic wall. Biopsy was taken and it showed non-keratinizing squamous cell carcinoma grade 3. She had an MRI pelvis with contrast at time of diagnosis, sagittal cuts showing the mass, it's big mass, and the coronal cuts and the axial cuts. The MRI, we found lymph nodes, bilateral lymph nodes, which is the most significant one. The cervical mass was 4.5 times 6 centimeter, extending into vagina with bilateral upper mild parametrial extension. She had bilateral external and internal iliac lymph nodes. Largest was 2.4 centimeter times 2.1. She was staged as stage 3C cervical cancer. So the patient received concomitant chemoradiotherapy with cisplatin weekly. She had boosting for the lymph node using SIP technique, VMAT, 56 Gray over 25 fraction for the lymph nodes and 45 Gray over 25 fraction for the rest of the target. She had an MRI at week 5, which showed marked improvement. This was the initial MRI, and that's her MRI after the concomitant chemoradiotherapy with marked improvement and regression in the size of the mass. Patient was decided for receiving brachytherapy using combined intracavitary and interstitial technique as she still had parametrial infiltration. The patient preparation is typically an empty bladder following catheter placement, followed by installation of 20 to 50 milli of normal saline plus 1 millimeter of contrast prior to CT and the treatment delivery. IV contrast can be used, but we didn't use it in that patient. CT imaging using a protocol of less than 3 millimeter slice thickness should be performed, and to have an empty rectum. We did an examination under anesthesia at time of brachy. Cervical mass was felt as a هو بيشتغل هو انتوا عندهم مشكلة يا شباب. هو presentation بتقلب لوحدها حاجة عندكم مشكلة. هو someone is حد رجع تاني. أنا كنت
هنا
فهو في
لا
يمين
مش يمين شمال بس.
ايوه ما هو يمين وشمال بس هو بيقلب اللي هو
معلش حضرتك ساعات بتدوسي هنا غصب عنك.
لا ما بدوش هنا غصب عني.
تمام هظبطها من عندي.
Okay, sorry for the interruption. So at time of brachytherapy, we did an examination under anesthesia and cervical mass was felt at the posterior left with parametrial infiltration more pronounced on the left side. That was a clinical drawing we had. So for target volume delineation, we know that the gold standard approach for contouring remain clinical examination and documentation along with the MRI at diagnosis and the MRI at the time of brachytherapy. According to the Jack Estro working group, they had several publications regarding contouring of target volume delineation, but it was mainly for the MRI-based planning until they had the CT-based delineation, CT-based planning delineation. Okay. For the MRI-based planning, the GTV includes GTV residual, which is the residual gross tumor volume for the primary tumor. CTV high risk includes GTV residual and the whole cervix and any residual pathological tissue, if present, and intermediate risk, which includes CTV high risk plus a margin plus initial macroscopic to be considered. Targets is contoured on axial sequence, but we have to check coronal and sagittal sequence to be inspected along with to ensure consistency along with the clinical examination and the MRI and the imaging modalities we had. Okay. The Jack Estro ABS recommendation for CT-based contouring, which Dr. Namet was one of the authors. They gave us great recommendations to have our target when we are using CT-based planning. We don't have an MRI planning, so we are using the CT-based. So no GTV can be contoured on CT-based planning. It's very difficult to assess residual, gross residual at time of brachytherapy on CT. So we omit the delineation of the GTV. We just contour the CTV high risk, which consists of the entire cervix and any extra cervical extension in regions of parametrium, uterus, and vagina. And it can be based on classification of clinical remission. Depending on other imaging modalities, we must have to delineate target volume delineation. We must have the MRI at initial diagnosis, the MRI at the time of brachytherapy, and preferably if we have transrectal ultrasound and our clinical examination to make sure that we are more certain about what we are delineating. Okay. So this was the delineation of the patient. So to reach this stage, we have to go thoroughly cut by cut and guided by the MRI of the patient. We don't do fusion. It's not recommended by the guidelines to have MRI fusion because we don't have the applicator inside. It would be a different position. So the fusion won't be the best option for us. So we open the MRI next to us and we delineate guided by cut according to the extensions of the tumor by clinical examination and by MRI at time of brachytherapy. So we delineated the patient and included all the gross tumors that was seen in MRI and including the whole cervix. That was the delineation. And then we have to check the sagittal planning to see if you are matching the MRI and the clinical examination, and to check the coronal to see all the planes in which we are delineating our target. Okay. Dr. Gheda will tell us about organs at risk. Thank you.
Now we shift to contouring principles of organs at risk. So again, we are guided as in the whole Egypt. In whole Egypt, we have no centers in brachytherapy that use MRI guided, except for one center in the Upper Egypt. So these guidelines saved us a lot and provided us with very, very valuable information about the CT contouring in the image-guided adaptive brachytherapy. And thanks for all the authors, especially Dr. Naamat and of course Dr. Amish, and also Dr. Primoz Petric, and many others that shared in a recent Brachythera course that I give myself permission to share some of its slides here because it provides very important information about the delineation of organs at risk. So the JIC-ESTRO recommendations for CT-guided or CT-based organ at risk contouring. There must be defined protocols for the delineation of the organ wall, like the contrast medium. And we actually, like Dr. Huda Al-Khodari said, that it is an empty bladder with injection of 20 to 50 millimeters of saline and 1 cc of contrast. And we found this bladder protocol is quite comfortable for us and achieving some sort of protection of the bladder from high doses. And of course, typically empty rectum. The main organs at risk that should be delineated is the rectum, the sigmoid, bowel, and bladder. Of course, anal canal, vagina, and urethra can be important in some of the cases, but it is not routinely delineated, actually. So continuing the JIC-ESTRO recommendations, the bladder and the rectum, the bladder point and the rectal point, and now we are using what's called the rectovaginal point in relation to the intracavitary brachytherapy application have to be reported. We actually does not depend much about that point, but the recommendations is to report that points that correlates with the urinary complications or toxicities like incontinence, and rectum like proctitis, fistula, toxicities, and the vaginal stenosis and shortening. About the vagina, ICRU 89 report suggested that there may be some other points other than the rectovaginal point in the upper and the lower vagina, but we are not using it actually routinely. So about these points, in short, the bladder point is the point of the highest dose in the bladder, and the rectum is the highest point on the rectum, and the rectovaginal point, as demonstrated in the figure, is defined as 5 millimeters, a point if 5 millimeters posterior to the vaginal mucosa from the center of the vaginal source. The assessment of small organ at risk volumes for brachytherapy planning and reporting, and the ICRU reported the 0.1 cc and the 2 cc is the most appropriate volumes, or those to these volumes that are appropriate, and we will know in the next slides why. And for the rectum, we need about 3 to 5 centimeters in the craniocaudal direction, or maybe longer, related to the vaginal source, and this part should be delineated. About the sigmoid, there is a great variety in the delineation of the sigmoid and personal variations, especially in the sigmoid. So if you have to be cautious, and here in Ain Shams, we are delineating, one is delineating, and one is checking the delineation, and it should be done in all cases in the delineation of the organs and the target, the organs at risk, and also the plan evaluation should be checked twice. Similarly, the bowel loops have to be identified near the uterus and need to be contoured in, yes, the same area of 3 centimeters. And also of the bladder and we said the bowel, the rectum, the bladder, and the sigmoid. There is 2 cubic centimeter is a strong correlation. The dose to the 2 centimeter cubic has a strong correlation demonstrated to clinical morbidity endpoints like cystitis, proctitis, fistula, vaginal stenosis, and diarrhea. So to stress on very important points, what is the organ at risk? And what is the 0.1 and the 2 cc from the organ at risk? Here is the rectum, sigmoid, small bowel, and bladder. The red area is the 0.1 cc. The blue area following the 0.1 is the 2 cc. And the green area is the area of more than 5 cc. So the organs at risk here are small normal tissue subvolumes located mainly in the mucosa and the submucosa in the organ walls. Not only the walls, but also the neural plexus and muscles that regulate specific functions in the bladder, the rectum, and the anus. And our main target is to give the highest dose to the target with a minimum dose to these all structures. So in the external beam radiotherapy, we are using what is called relative volume of irradiation. We are irradiating the whole organ. The external beam is giving radiotherapy to the whole organ from the outside. So it is a relative volume to the whole organ, not a part that is near the source. Actually, brachytherapy is the opposite. It is an absolute volume. It is a very small part that we are making sure, of course, in all the 4 sessions, that it will be the same part for reproducibility by the protocols we are using in filling or the emptying of the organs at risk. And these are the 0.1 cc and 2 cc. So here in this figure, and this is the sentence that is said by the Professor Primus Petrick, which is a high scientific professor and highly knowledgeable. This is a concrete volume. This is a specific part of peritoneum, fat, muscle, lamina propria, mucosa, nerves, and vessels. And here is the DVH that will show us the 0.1 cc and the 2 cc. Here in the 2 cc, like we see in the sigmoid, in the rectum, and here in the bladder, it's not the D maximum. It is just a point or just an area, sorry, that will receive the dose, the particular dose in through the brachytherapy, and this is the minimum dose that will reach this area. It is a minimum dose to the 2 cc. The dose to 2 cc is the minimum dose to 2 cc. What is the area of the highest or the maximum? It is here in the red between 84 and 99 grays, actually. So transferring to another point or talking about another point, should we actually contour the organ or contour its wall? Back to the Jack Estro recommendations, it should be the wall. However, the small thickness of the wall of the organ, because we don't want the DVH, we actually want the D wall H, the dose wall histogram. But actually the walls, like the figure in the right, in the left, sorry, these are the delineation of the wall. We want the wall, not the urine, and we want the wall of the rectum and not the stool or the empty area inside. So the organs should be delineated slide by slide and should be delineated as a wall. But however, the small thickness and actually the time consuming and the many uncertainties that we can face will make us contour the organ. And this is recommended by the ICRU 89. And this is the graph to make it more clear. This is a DVH and this is a DWH. This is for the volume that we are using, and this is the wall. And look at the point, there is no 0.1 cc here, the 2 cc and the 5 cc on the figure and in the graph. So actually the D2CC, the dose which reaching the 2cc is very close from the delineation of the organ and the delineation of the wall. Why? Because 2cc actually, the site of it is in the wall, but the 5cc is not. But actually we do not use the 5cc, we are using the 2cc. So we are delineating the organ, but targeting the evaluation of the wall. So the scattered versus concentrated high dose region. That means that we sometimes want local control to be high without compromising the organs at risk, but it may be not applicable. So we are accepting sometimes for a high dose regions. We should see not only the 0.1 and the 2cc. We shall know the distribution of the high dose region. Here in the sigmoid, it is distributed in 2 parts. So it may be accepted, but the concentrated high dose region in the rectum or in the bladder may be not accepted. Also very important to the point to demonstrate is understanding that the sigmoid and the rectum may have a high dose. All together, they are delineated, we are delineating them as 2 organs, the rectum and the sigmoid. And the 0.2 cc is good here and good here, but if we see this actual point, we can see that this area in the rectosigmoid junction may have a high area, a high dose area that can compromise the outcome. So we can adapt the contouring. Maybe we can elevate the delineation of the rectum upper or the sigmoid down to make this area in 1 part and show or see if it is actually accepted or not. So the uncertainties, of course, we all have uncertainties. Actually, when I'm delineating and my colleague is checking for my delineation, there is variation. But what variation could be more important than the other? Of course, near the variations near the target, so it should be cautiously monitored. And these are the uncertainties per brachytherapy fraction, the 1 standard deviation, and I will show you a graph here. The source stress, that means that the D2CC, the dose to the TCC uncertainty per fraction could be up to total of 21 to 26%. The most common is the most high percentage is the intra and interfraction contouring, which raise the importance of the checking of the contouring and make it slice by slice without any extrapolation, like advised first by Dr. Ahmed. And also the second is the inter and interfraction, but this is total, not per fraction. And this is the interfraction variation that could that could happen. But actually we couldn't, maybe the uterus is elevated and then it will be retroverted somehow or antiverted somehow, the sigmoid filling the rectum, the bladder. This is an interfraction variation that can cause some variation to the dose to the 2cc. And this is the clinical importance. When I say that I give 70 grays, so I am actually giving 65 to 75 grays. And I'm not actually sure, I'm not that sure what dose will reach our organ at risk. So finally, achieving the hard equation, although the organ at risk sparing is expected to improve quality of life for many women, control of the cervical tumor continues to be the primary importance. And in situations in which organ at risk constraints cannot be met despite best efforts, tumor coverage may be prioritized after careful discussion with the patient. Thank you very much.
Thank you, Dr. Ghada, for this very nice presentation. And because of shortage time, we'll move to next presentation. Plan evaluation. Okay, for plan evaluation through Dr. Christine Reda, lecture of clinical oncology and Shams University.
Thank you, Dr. Ihab. It's my pleasure to welcome you all to Ain Shams University International Conference. Here we come to our last step. Thank you. Okay, thank you again. Here we come to our last step before the patient go to the treatment room, to the treatment machine. Here we comes to the evaluation of the plan. We have done the perfect organ at risk delineation. We have the perfect target delineation. Now comes the truth, the evaluation of all the steps before. I'm Christine Reda. I'm lecturer of clinical oncology and proud to be Ain Shams University. I will not be that boring for you, but just have a very brief look about the history of brachytherapy. The word brachy stands for short. It's a Greek word, stands for short. So brachytherapy, it's standing for a short distance treatment. We are treating the patient from a short distance. It starts actually in the early 19s, where we start treating skin cancers and then going to the prostate cancers and at last the brachytherapy for the gynecological tumors. A very important point here that the external beam radiotherapy was not invented till the 1950s and 1960s. So in the early 19s, we only have brachytherapy. There was no external beam. The first teletherapy Cobalt 60 machine was invented in 1960. The historical systems of brachytherapy starts by the famous Stockholm system. It's about 1910. It started by small vaginal boxes and an intrauterine tube. They use a radioactive radium-226. In the Stockholm system, they used a very high doses of radioactive iodine, but in a short period of time, actually in 2 to 3 fractions. And then it evolved to the Paris system. The Paris system, which about 1920, they changed the loading of the radium to shorter or to smaller intensity radium, but for a longer period of time. So the patient have to be immobilized for about 1 week with a more exposure to radiation. And at last, this famous Manchester technique. And here there's a very important point that the previous systems, the Paris system and the Stockholm system, there was no definite volume for treatment. There was no definite radiation volume. The radiation volume was proportionate to the amount of radium that you apply. But here in the Manchester system, they defined a definite point, which is point A and point B, where point A stands for paracervical tissue and point B stands for the pelvic wall. And here we start to talk about points. Point A and point B, they actually prescribed 77 grays to point A. So here are the 3 historical brachytherapy systems, the Paris systems, the Stockholm system, and finally the Manchester system. From here, we start to move on. Also, there was a change in the dose rate. Imagine that we started by very low dose rate of 0.5 CGY per minute, going through to high dose rate of 200 and 300 CGY per minute. Okay, to start a very good quality brachytherapy, you should study by heart. If you want to study brachytherapy, if you want to learn the brachytherapy, just study those very important articles, please, which are the ICRU 38, published in 1985 about the intracavitary brachytherapy, the ICRU 58, published in 1997, the MRI-based brachytherapy of the Jack Estro, and the ICRU 89, published in 2013. And the very famous, and the landscape, and the very famous EMBRACE study, which presents the benchmark of brachytherapy, going through the EMBRACE in 2008, which was only an observational study, and moving on to the EMBRACE published, EMBRACE 2, published in 2016, which was an interventional study which published the contouring and reporting according to Jack Estro recommendations, making the basis of all the contouring, the reporting, the planning of intracavitrine and interstitial brachytherapy. These are very important studies for any radiation oncologist practicing brachytherapy. Okay, for the workflow of a patient, the patient starts with a clinical evaluation and going through patient preparation. After the patient preparation, as we saw in the video, after the patient is well prepared, she goes for imaging, a CT imaging, and then the applicator insertions, the contouring. Now, in this lecture, I'm only concerned with the 3D dose planning and reporting. This is a very important step before treatment. So we have a journey, as we said, that we started from the Manchester technique, defining the dose to point A, we're moving from point A to the HRCTV, to defining a volume, which is the high-risk CTV. In this journey, it would never happen only because the great evolution in the imaging from 2D X-rays to CTs and to MRIs. As my colleagues presented the target volumes, we have 3 important target volumes to be defined. The residual GTV, presenting the macroscopic disease at time of brachytherapy, the adaptive CTV, the high-risk CTV, which presenting the residual GTV plus the whole cervix, plus the pathological residual disease. And this pathological residual disease, we used to call it the gray zone, the gray zones in the MRI. And the adaptive CTV, intermediate risk, which is the macroscopic disease at time of diagnosis. So here we have got a very 3 important target volumes. With brachytherapy, we can do this, what you can see here in this picture. We can do what we call it a dose painting of the cervical cancer. So we can apply a very high dose to the GTV, which is about 110 gray EQD. For the high-risk CTV, we're applying 90 grays, and for the intermediate risk, applying 60 grays. That's the great benefit of brachytherapy. That's what you cannot do actually with external beam. So the first step for evaluation, we have to use the same term. And the common term is the EQD. What is the EQD? It is the total equi-effective dose, which is calculated actually for each brachytherapy session, for the 4 or the total sessions of brachytherapy, and then calculated for the external beam, which the patient received for brachytherapy. And lastly, we should calculate the EQD for the external beam plus the whole sessions of brachytherapy. I will show you just an example here for the EQD calculation. That's just an example. We all know about the alpha-beta ratio. Our great physicists, Dr. Amin, Dr. Sumaya, Dr. Hani, thank you, have learned us what is the alpha-beta ratio. We all know that the alpha-beta ratio for the tumors is 10, and for the organ at risk is 3. So we have an example if we are prescribing for point A in external beam 45 gray, 1.8 gray per fraction, we have a total dose of 44 EQD2. For the brachytherapy, if you're gonna apply 7 gray in 4 fractions, so it's total 28 gray, a total dose of 40 gray EQD2. So now we have a total dose to the cervical tumor, which is 84 gray EQD2. Is this clear? I hope this is clear. I'm just clarifying the term that we are not talking about the external beam separately and the brachytherapy separately. We have to combine those in a term of the EQD2. So for the first look, when you have the evaluation, when your great physicists finish the plan and tell you, yeah, doctor, you have to go now and evaluate and accept your planning. The first look, you have to talk about your target, the HRCTV. And as I said, we are talking about the EQD2. There are 2 important parameters to evaluate the target, the HRCTV, which is the D90 and the D98. What does it mean, the D90? The D90 is the dose to the 90% of volume of the HRCTV. And also the 98, it's the dose to 98% of volume of the HRCTV. For each parameter, we have a soft constraint and a hard constraint. Again, what does it mean, a soft and a hard constraint? For the soft constraint, we want to apply this parameter or these constraints to about 70 to 80% of patients. For the hard constraint, you must apply this for the majority of patients, for the 90 to 95% of patients. In other words, the soft constraint means that we are aiming to apply these numbers, to apply this constraint. For the hard constraint, you must. This is your red line. You should not exceed this. You should not accept less than this. So for the D90, you should not accept less than 85 gray EQD2. For the D98, you should not accept less than 75 gray. By all studies, we found that those two parameters, the D90 and D98, actually contribute to the local control. So, I mean, if you compensate in these two parameters, you are compensating the local tumor control, you are compensating the patient's survival, actually. So, important question and a big point to discuss. Shall we document or shall we prescribe the dose again to point A? Can you remember point A of the Manchester system, the 1930s? Shall we still prescribe the dose to point A? This is a big question. This is a big debate about it. Actually, point A still is a good presenter of the D90 HRCTV only in small tumors. I mean small tumors which are confined to the uterus. In these cases, you can prescribe to point A because it will be a good representer of the D90 tumor. According to the Embrace, they advise to keep the point A in institutions with MRI-based brachytherapy to be more than 65 gray, institutions using CT-based brachytherapy to be more than 70 gray, and in 2D X-ray-based brachytherapy to be more than 75 gray. Again, we not prescribe to point A anymore, but we just document the dose to point A. Going through the organ at risk, thanks for my dear professor and colleague, Dr. Ghada. It makes very easy for me now. For the organ at risk, we have a very important parameter to define, which is the D2cc or the D2 centimeter cubic. What does that mean? It's actually a very small volume, which is in close proximity to the applicator. I hope you can define the applicator. It's here in the middle of the uterus. Okay, so we define this D2cc to be the very small volume of the organ at risk, which is in close proximity to the applicator. We suggest that these volumes will receive the highest dose from the brachytherapy. A very important point I want to bring forward is that for the hollow organs, the radiation clinical effect is related to the irradiation of the wall and not to the organ and to the lumen. For the brachytherapy, for gynecological brachytherapy, we have three very important organ at risk, which are rectum, bladder, and sigmoid, defined by the ICRU. But we also have two important points. Here we can find by the red arrow, the bladder ICRU point and the rectovaginal ICRU point. The bladder ICRU point, actually, it is situated near the bladder neck, and it's very correlated with urinary incontinence. So in some situations, when you are accepting your plan and you have a higher dose, a very high dose in the bladder, please go to your physicist and ask to see where is this 2cc, where is the high dose. We are not just accepting numbers. Go and ask where is this 2cc located. If it's there high in the trigone, it could be accepted. But if it's there near the bladder neck, near the bladder ICRU point, this will be a very great risk for urinary incontinence. For the RV point, rectovaginal point, it also related to the vaginal stenosis. All this point should be documented in your brachytherapy report. So according to the Embrace, we have again soft constraints and hard constraints for each organ at risk. Here for the bladder, you should not exceed a total dose EQD2 of 85. For the rectum, you should not exceed a 75 grade and again EQD2. For the sigmoid, we should not also accept more than 75 EQD2. This D2CC for the bladder, rectal, and sigmoid with in many studies actually correlated to all the clinical morbidities and the radiation-late toxicities like bleeding, proctitis, cystitis, and fistulas. These complications should be discussed with the patient. We should have time with the patient to discuss each point, each side effect, and the probability to happen. For the rectovaginal point, according to the EMBRACE, we have a hard constraint that it could not exceed the 75 grays. I can tell that this slide is the central core of the talk. Please keep it. Please keep it by your side for your daily use. This is our guidelines. These are the main benchmark of brachytherapy. It is the EMBRACE2 protocol constraints. Here we come. Some situations we are facing a very huge GTV, a very huge residual of tumor after external beam, which is not covered at all by intracavitary brachytherapy. Here we have to move one step to a dose optimization by interstitial brachytherapy. In this example, please have a look to the dose, the D90 to the HRCTV in the standard treatment. It's only 80 gray EQD2. And the D98 to the CTV high risk is only 71 EQD2. As we all know that by getting a bigger, when having a bigger GTV, when having a bigger target volume, you should have a bigger and a higher EQD2. So for this big HRCTV, for this huge HRCTV, an 80 gray EQD2 is not enough. So we move to dose optimization by interstitial brachytherapy, which is an insertion of needles. And here you can clearly find the difference that we increased the D90 CTV high risk to 89 grades. There is 9 grades increase in the D90 to the HRCTV. And not only for the target, we have now increased the dose to the target, but 9 grades by insertion of needles. But again, for the organ at risk, we have here an example of the rectum. You can clearly find that in the standard treatment, which is an intracavitary brachytherapy, there was a 70 gray to the D2. But for the optimized treatment after insertion of needles, we have saved 9 grays. So it became a 63 grays for the rectum. Now we are all satisfied. We have a good delineation. We have very good contouring. We have a very good insertion of the applicator. But actually, shall not be the truth. There is a great difference between reality, what the patient will receive, and the dream. We dream of HRCTV with a D90, but this does not usually happen. We dream that the rectum will not receive more than 75, but this will not actually happen. In plan evaluation, what I want to conclude for you, that we start with the planning aims. What is your aim? What all our aim? That we have an HRCTV D90, 95, that we have an rectum, bladder, and sigmoid organ at risk, all within the tolerance. This is our aim. This is not your prescribed dose anymore. This is only your aim. And then we go for an individualized treatment for every patient, for the target and for the organ at risk. We go then to the plan approval and the prescribed dose. So now, if I asked any of the radiation oncologists, what is the dose you prescribe for cervical cancer? He says that it's 7 gray. Actually not. You are not prescribing 7 gray. You are aiming for 7 gray, but the patient actually received maybe 6 grays, maybe 5.5 grays. This is the prescribed dose. This is the reported dose that should be reported. And then we should have our cohort of patients, our group of patients. Then we get our mean dose to the patient, what our institution data, that this is the mean dose to the HRCTV we have, and the deviation, the standard deviation for our own patients. So don't panic. Sometimes you will be happy about your plan. Sometimes you will be sad. Sometimes you just have to accept the plan. There is no other options. You tried your best. You go for dose optimization with interstitial and nothing to do more. You have to sit down, talk to your patient, and tell her the situation that we have to increase the dose to the target. On the other hand, we have to accept some increase in the complications or side effects of the organ at risk. And then you come to a decision. Thank you very much.
Thank you, Dr. Christine Reda, one of our promising staff member in Ain Shams University. Again, for such time, we postpone question to the end of the session. And now we will go for virtual presentation from London with Professor Dr. Huda Al-Bouz. She will present challenging cases. It is ready? Ready?
Hello, thank you very much for inviting me. I am ready, but can I just tell your IT that it says host has disabled participant screen sharing, so I can't screen share mine. Still says host disabled participant screen sharing. So if your IT is on site, I'd appreciate if they can unlock that. Yeah, thank you. Right, can I just check that sorry, just a second. Slideshow. Can I check that you can see my presentation?
Sorry,
Hi.
doctor, I cannot see your presentation.
You can't? No?
Not
No.
yet.
Okay. Right, can you see my presentation now?
Yes, Dr. Huda. Okay. Thank you.
And is it on
ثانية راحت فين؟
sorry, can you see it now as a presentation mode?
Yes.
Yeah, lovely. Okay. First of all, thank you very much for inviting me to speak on this lovely meeting, and I'm really sorry that I missed it. Haven't been able to be there with you. It's great to see your work carrying on and getting bigger and bigger. I'm really proud of it all being, having
Doctor,
mentored
can you
you.
make it full screen?
I have made it full screen, but
It's
let
still
me
on present view.
right. Is it now on full screen?
Yes, thank you.
Okay, and can you see my cursor at all? So I can use that as a pointer.
Yes, we can.
Lovely. Okay, that's great. So, I'm, as you know, for those who don't know me, I'm a consultant clinical oncologist in Bristol, and I've been delighted to have been mentoring the Ain Shams University group through their brachytherapy journey. I have made this presentation a bit shorter because I can appreciate, I think you're 2 hours behind, so I just thought I'll just help for the next session. So I'm by no means that I'm actually presenting this to show off cases, because obviously you have been there, you've started doing complex cases, which is brilliant and really reassuring. But maybe there are some learning points that I would like to bring across. Specifically, I mean, I don't know if we still have any surgeons in the room or not, but specifically things that I have spotted, because I have been going in and out of the meeting during the day. And I can see that there is a lot of concentration about relapses being even after chemoradiotherapy that are actually definitely for exenterative surgery, which is something makes me worry slightly, because certainly the guidelines now, as in the Royal College guidelines as well, is that you need to be thinking about using brachytherapy for smaller volumes if there is a relapse and it's actually a contained relapse. And once you get to the point where you have the ability to use different procedures and more complex procedures, then you will be able to get to that, hopefully. So the key for this presentation, I'm just going to present that actually the key for it to be able to deal with challenges is having different tools to be able to get to those challenges, and having different types of applicators. This is definitely a bonus, and that is what makes a department moves forward in the way of their training. You've done exactly the right things, as in, you know, you've been trained locally. Yeah, you've had me visiting. You've actually managed to go away and see other departments internationally. You've hooked yourself with other clinical trials, hoping to actually be involved in that, because that is the key for getting into the complex cases, which is really important. And thank you for the presentation, Christine, that you've actually mentioned about all the issues about the planning and so on, and the difference between what you're aiming to get and how you can guarantee that this is actually what you're getting. A very important talk is actually the one that's going to be presented later on by the physicist from Portsmouth, Mr. Polak, because I think there is, you know, you could actually assume that you're getting all these doses right. Computer tells you so. You have done the very perfect insertion. By the way, there is no perfect insertion. Even I wouldn't do a perfect insertion. There is always, every insertion is different than the other. But it's important to know that the device is actually delivering what it is delivering, what it is telling you on the computer that it's delivering. So there are checks that needs to be doing, and I'll just need to add to that. So one of the things that I'm going to just go through cases and maybe highlight different issues that are with each case about the importance when a department like yours, that is actually now a referral department for different cases that are being done, not even just locally in Ain Shams University hospitals, but actually being referred to you from different hospitals. Key with this case, I would say, is the peer review, or the revision of reviewing the previous external beam radiotherapy that this patient would have had. Hopefully, as I've said this once, twice, and 3 times, hopefully, if you've actually get involved before the patient starts external beam radiotherapy. This is a scenario of a patient who's actually been treated in a different department, which is miles and miles away in a completely different city. They don't have brachytherapy. We actually treat their cases in Bristol. So the clinician has actually spoken to me, the clinical oncologist, and we've shared on Teams looking at the scans in order to try and see what, you know, before she started the radiotherapy, this patient had a cancer that's within the vaginal vault, very similar to the patient that you've shown earlier, but there was a nodule which is actually in the parametrium, so a node in the parametrium that was completely attached to that disease. Clearly, with your external beam radiotherapy, and I can see that you've already started doing concurrent boosting. Her question is, shall I boost this, or is this going to be close to your volume? So I've recommended that they don't boost that node. So they boosted other ones on the pelvic side walls, which is great. You have to import those scans and the actual plan in order to be able to know when you're assessing the doses, like you said, Christine, about the doses for the normal organs. You really need to know whether that area, the 2 cc, was that close to a boosted volume or a boosted node within there. So anyway, with this patient, after external beam radiotherapy, the tumor has shrunk, so did the lymph node, And actually, after having been, all this was actually one block, they split it into two. So actually it made the brachytherapy more challenging. However, having access to an interstitial cylinder, so that has a central tube that you could use either for an intrauterine device or for a central canal without actually a tube and the needles, that actually helped a lot. So in this situation, that was actually used in theatre. Patient is still anesthetized and used the needles all around, but actually with the help of the ultrasound guidance, we've actually managed to insert a needle within that node that was slightly away from it. Simply, I couldn't leave it alone because we've already finished the external beam radiotherapy. So that was one case I just wanted to show that there are other things that can be done. Also, there's a more simpler one. So this patient had also a vaginal vault relapse before radiotherapy, and it was actually she didn't have a uterus. And after the relapse, after external beam radiotherapy, she's responded very well, and we still had a little signal just out. So this is actually at the top of the vagina, and as you go down, it starts from the right fornix of the vagina. This patient, unfortunately, was unfit at all for anesthetic, neither general nor spinal. So it was very, very challenging. So what we've done is we've used the multi-channel cylinder without the use of any needles. It's, yes, we do have the facility, but you have to adjust yourself according to what is actually what the case is in front of you. And the last thing you want is to have harm to this patient. And we've done several anesthetic assessments, and it was impossible to do so. So what we've done is we've done what we call a day 0 MRI scan. So which means that the patient comes to the appointment. We insert the appropriate cylinder size, and we do an MRI scan and then send the patient home. Simply because she doesn't really need to stay all that length of time until we've actually done the planning. So send her home, and then she comes back the following day to have her procedure as an outpatient. Doesn't need to be admitted, doesn't need to be under general anesthetic. So with the applicator in situ and an MRI scan, that is actually outlined. The area that was outlined, unfortunately, is slightly a bit further from there. But because you have got multi-channel cylinder, you can actually aim to treat this with the D90 and the D95 being very acceptable without overdosing the rectum and the other organs at risk. So that was quite helpful. In terms, this case is actually, I would have loved to have surgeons in the room for this one. So this patient had radical hysterectomy. It was about a year before she presented to us with a relapse. And the histology was reviewed, and actually there was no indication whatsoever for adjuvant treatment. Unfortunately, she had a relapse, and the relapse was right in the middle between two loops of the intestine, and you have the vaginal vault lower down here, completely retracted within this horrible mass. So the answer would have been a radical hysterectomy, actually, sorry, not a radical hysterectomy, even an exentration, and it would have been a full exentration. So both bladder and bowel would have gone. So we've, because the patient didn't receive radiotherapy or chemoradiotherapy, so we've decided that we would go ahead with radiotherapy. She was adamant that she would not have surgery. And by the way, we have discussed both options with this patient. But she decided that she does not want to have surgery. There is no way that she would live with a bowel diversion or lose her urinary functions, and had lots of social issues to actually stop her to do that, which we totally agreed. I think she was just about right to do that. So what we've decided is to go ahead and do the radiotherapy. So full pelvis treated, didn't have any lymph nodes, so we didn't need to boost any lymph nodes, had chemoradiotherapy, combined chemoradiotherapy. And unfortunately, after finishing the radiotherapy, she's had some response, but disappointingly not a lot. One of the things I must admit that this actually, I always find it really disappointing for those who have lower grade cancers. They don't tend to respond very well, and this was one of them. So using at the time, actually, we didn't have interstitial cylinders. And in fact, her vagina was so narrow that if you even insert a ring, so which I've tried to insert a ring and then needles, the ring would stop there, so really far away from there. And one of the things which I'm sure I've talked about before, that you need to avoid being very, that you have a full length of the needle or a very long length of the needle out of the applicator within there, because the risk is that the needle snapping within the patient. So you really need to be careful about that. So decided not to use the 3D interstitial applicator ring, but rather than that, I've actually used a guiding tube for the central needle insertion, which is this by itself, not with anything else. She didn't have parametrial insertion because this is actually a relapse within the intestine, and it wasn't anywhere near the parametrium. The parametrium has gone with her radical hysterectomy. So it was such a weird relapse. So what we've done is we've done the guide with that tube rather than having 3 needles, because it was such a far away in, and there was a great risk that you're not going to be able to see it properly, to guide 3 needles. And certainly with 3 needles, that's very, very hard for the physics team to be able to delineate the exact position of the needles. They actually cross over very easily. So the best thing is to have a template to guide them. So this is what we've done. Patient was fully consented that actually, despite all what we're doing, you may need to have surgery, at least a colostomy, because of the intestinal obstruction that we're expecting. So we've had the planning with the brachytherapy, and actually I did not consider that as an OAR. So in fact, the organ at risk in terms of the intestine, part of it, the one wall I've considered it, but the other wall was actually part of the high risk clinical target volume. After 3 months, we still had the same thing. And after 4 months, I was losing hope that this was ever going to go. And then amazingly, at 6 months, this was what happened. But actually, the dome of the bladder was completely attached to the intestine, to the rectus sigmoid. So actually, at that point, I did warn her that she may end up with intestinal obstruction. We've talked about certain different types of diet in order to avoid constipation, and also consented her about ongoing hematuria because of the way it is. It carried on 12 months, 24 months, and actually she's now 5 years out. Nothing has happened. She's actually continuing exactly the same, and I'm scanning her annually with an MRI scan. One of the things I must admit what happened is that she had a ureter was completely obstructed, and she ended up having a ureterectomy on one side, and nephrectomy on one side. But she's absolutely fine at the moment, and she's now 5.5 years. This patient here was unfortunately diagnosed at the end of her pregnancy. Or she started bleeding at the end of the pregnancy. Was very unlucky that she actually presented at the time of COVID. So at this time in the UK, it was very difficult to see a GP. She actually was managing to contact the GP, but had no referrals. And what she was complaining of, never mentioned that she was bleeding, because she's thought because she's had a baby, she's continuing to bleed. But all she was worried about is her back pain, and she was being given lots of painkillers. Unfortunately, this is what she was found to have. So this is what she started off with. Amazingly, she didn't have any lymph nodes involved, and she's had chemoradiotherapy, and we ended up with a very good, if you look just on the sagittal scans, you would think she's had a very good response, and you'll go ahead with a ring and tandem without the need to do any needles. In fact, if you look with the horizontal views, you will actually see that her cervix was very, very bulky. It doesn't show it here, but it was very, very wide. So if you ended up with a ring, you're likely to be able to miss all this. One of the things, so in fact, she doesn't have a GTV, and it's unlikely that you would have recommended having needles. But one of the things I must add to the talks before me, that if you have a very huge tumor, then you think about giving or parametrial invasion, that you want to use needles because you want a wider coverage. In fact, I will argue that actually even with this one, where there isn't a tumor but a bulky HRCTV, by the time you cover this, you're unlikely, despite no presence of tumor, viable tumor, you're probably going to insult the organs at risk with a very high doses. So that is more of a reason not to use a ring and tandem by itself. With her, I've actually used this applicator, which is called an Arbus applicator, which has both straight needles and oblique needles, because I didn't want to use exactly the same on both sides for her. So that gave me that flexibility. So on this side, I've used the straight needles. There was no reason to go oblique. In fact, if you would have gone oblique in this side, you would have gone straight into the parametrial vessels or uterine artery. So therefore, I've used the oblique needles on this side only. And this is how it actually looks on the images here. So and then 3 months post brachytherapy, she's actually continued to have complete response, still bulky from his cervix, but actually started to shrink and evolute, Marlene. She's absolutely fine. She's now a year out from her, or actually 18 months out from her treatment. And then this case here was a patient who presented, she had a very interesting case because she's had bicornate uterus, a didelphid uterus, and also a large cervix cancer, which actually came just out of the ectocervix rather than inside from the cervix itself. Unfortunately, I couldn't get an image that you could see both images at the same time. Huge cancer, but mainly into the vagina, and in fact extending to the lower third of the vagina, and therefore with the external beam radiotherapy, we have covered the both inguinal lymph nodes for her. So post radiotherapy, again, disappointingly, it was the same. I've tried to argue with the surgeons whether this can actually be actually excised even, or just shaved. The worry was it was completely stuck to the whole of the vaginal wall, but actually it wasn't viable. It wasn't viable. So they've done an examination under anesthetic. We've had multiple biopsies, probably from her 3rd month post-treatment to about the 8th or the 9th month, nearly probably a couple of times or 3 times that she had an examination under anesthetic and biopsy, and it wasn't viable, but she still felt the mass. Unfortunately, our hands were tied that we actually couldn't do anything else. But so so this is post-external beam radiotherapy. So what we've used the interstitial cylinder in her, and so the intrauterine tube went into one of the cornea of the uterus, and the interstitial cylinder here. But actually, that again, even though it does divert with the needles, even that it actually you couldn't cover all the areas. So in fact, with this patient, and you can see here, you're not actually close enough to the cervix because of all the bulkiness of the tumor. So I've used all the needles in the interstitial cylinder, but also added to this free needles, which I don't know if you can see, but there were free needles that are added also in order to extend the dose laterally to be able to cover it. And this is, as I told you, about a few months after, there was still, this is when, at the time when on the PET CT, this wasn't viable. She had an MRI scan and it was that the residual disease. You can feel it on examining. She can feel it. She was a very slim lady and she can feel it herself, and it was difficult for her to sit down. But then after that, all of a sudden, it actually responded very well. My next and final case, this is actually a patient with vulval cancer. So this patient had her pre-treatment, had a huge disease that was actually involving the anus as well. Again, radical surgery was on the cards because that's historically, this is what you would do. But we've actually decided to go with concomitant chemoradiotherapy and interstitial brachytherapy for her. So after 5 weeks of chemoradiotherapy, she's had a brilliant response. And therefore, we've used the interstitials. We've actually used a multi-channel cylinder and an intrauterine tube. And I'll show you now what we've done. And also this applicator here that sits on the cylinder itself, which is simply a perineal template called Kelowna. So we've used the needles around this in order to go straight into this, but obviously on the other side, I'm sorry, this diagram is the wrong diagram. So it's the other side because you actually leave the needles where the area of bulk, which is the posterior area. So here, and as you can see, so an intrauterine tube, but despite the fact, and actually the reason I'm adding this case is because although I am not treating the uterus, and in fact the uterus didn't have any dose, by the way, but for stability. So one of the things I want to highlight is part of the brachytherapy. The procedures are very long. You do the procedure, the patient goes and have the scans, the patient comes back, wait for you to plan it, mark it yourself, and then the physics team to work on it. One of the things that you have to always bear in mind that you may be happy. I know you've marked the skin and everything might have not moved, but the more, in order to be able to make sure that this application does not move and it's rigid where it is, I've chosen actually to still put an intrauterine tube, although that was not loaded, and the cylinder here without needles, but actually used all the needles that are actually in the perineum. So as you can see here around this area, and the multi-channel was actually treating the lower vagina because it was vulvovaginal. It wasn't just vulvovaginal, not just vulval cancer. So we've managed to put all the needles in the area, and this one was done completely clinical without ultrasound guidance. I mean, we've had the ultrasound in the room anyway, but this is just to guide the uterus, and it was an easy insertion. But for the needles, it was completely clinical, and the insertion of the needles just about where it needs to go without the need to actually push them higher up. So, and she's 6 weeks post interstitial brachytherapy. And actually I saw her, I'm sorry, I didn't put the picture now. And for the 3 months, she's actually doesn't have any evidence of disease. And the telangiectasia has settled really well. So that's it for me. And I'm open to questions if you have any questions for me.
Thank you, Dr. Hoda, for this elegant presentation. I have one question, please. I am Dr. Ihab. For the first case and second case with parametrial lymph node or local recurrence at the vaginal vault, did you insert the needles guided blindly or guided by transrectal ultrasound or something else?
Transabdominal ultrasound.
Transabdominal.
Yes, and I did use we've used in both cases, we have used transabdominal ultrasound.
Would you like to use transrectal ultrasound?
I'm not very, I don't like it. We have it because we do prostate brachytherapy. But the transrectal ultrasound, the annoying thing about it is as you are in position when you're actually doing the insertion, the retraction when you're using it, which by the way, I mean, I know you've been using speculums as I can see in the videos, but we actually like to use retractors rather than speculums because that gives you more of a space to be able to angle the devices as much as you can. So to have that and the transrectal ultrasound in the position, that actually doesn't help us at all.
Okay, for the last case of vulvar recurrence, I have a patient like this. She has vulvar carcinoma treated with surgery in 2019 and received post-operative radiotherapy, then comes in 2023 by local vulvar recurrence.
Okay.
It's exactly like the picture you saw, we saw on the screen. Do you think we can use our mixed template to put interstitial implant needle in this tumor without further external beam irradiation?
I wouldn't do external beam radiotherapy again for her. If she doesn't have recurrence in the inguinal lymph nodes, and this is an isolated recurrence, so if you do a PET CT scan and you're sure that this is an isolated recurrence,
yes,
and you know that the surgeons will not operate again, which I'm sure they wouldn't, because obviously she was post-operative and you've given her radiotherapy, so they don't like to actually touch those with a knife. So yes, I mean that is an option. It depends how fit she is and how well she is to tolerate such procedures. As you know, most of these patients we tend to have, we might have given them external beam radiotherapy as in electrons. But if it's possible to do, if you're actually sure about the extent of it clinically and you're able to examine the patient, a template with needles can actually work, yes.
Okay. And how much dose?
That's the other question, is how much dose. So you're actually
this is Dr. Darwish's question.
Yes, I mean that's the $1 million question, I think, because you've already had the radiotherapy before. So I gather she's probably had about 55 gray equivalent.
She received about 45 gray at initial presentation as a post-operative treatment.
Was it 45 and 25?
Yeah.
45 and 25.
Yes, 45 and 25, yes.
Okay. So actually you do have room to give her brachytherapy as if, and she didn't have a boost?
No. She has only 45 gray as an adjuvant treatment after surgery.
Okay. And
in 2019.
So what was the indication for her to have post-operative radiotherapy?
I don't remember exactly, but
you don't know.
Okay,
I mean, I'm surprised.
Maybe limited margin, I think so.
Okay, in that case, I mean.
And the poorly differentiated tumor, both.
Yeah. So I think if it was a local issue, I mean, I wouldn't have given 45 and 25. I would have given higher dose to the vulva. So not the whole pelvis, but to the vulva. I think the vulva should have been boosted at the time with external beam radiotherapy. So I think the key issue is if she is someone who's not from your department, you do need to know exactly what she was given, because 45 and 25 certainly wasn't enough for her at the time. So if you're giving now brachytherapy, as if you've given the 45 and 25, and you are going to give her aiming for, so the aim with the vulval cancers is about total of 65 gray, so 65 to 70 gray. I wouldn't go higher than that. So forget about what the brachytherapy for cervix cancers, where you're aiming between 85 and 95. For the vulval cancers, I would aim between 65 and 70 gray. I wouldn't go higher than that. So you can split that into 3 or 4 doses, whatever.
The floor is off. Any question?
And so you're going to count, you're going to use what you've had in 2019 as if this was the radiotherapy that she's had, and just add the brachytherapy to that. I mean, you could allow higher, because obviously there is time for tissue recovery.
Yes.
I hope that Professor Amin is there, and I'm sure in his talk, which I'm sorry I'm not going to be there for the talk, but in terms of tissue recovery and how that can be calculated, this is actually a good 3 or 4 years since she's completed treatment, and I think you should allow for that as well. So probably I would expect that a 6.5 gray to the HRCTV or whatever you're actually outlining at the point is probably going to be enough per fraction.
6.5 per fraction. Or how
I would
much
say
fraction?
about 6 to 6.5 gray. I wouldn't go higher than that. Remember that these tissues are very easy to necrotize, so you need to be very careful with that.
Yeah. So 6.5 gray for how many sessions?
I mean, you'd have to work it out. I think it's probably 3 or 4 fractions, but it depends what dose you'll be able to achieve, because it depends on the needles that you're gonna put. So it's hard for me remotely to be able to tell you exactly what it is, but I think the bottom
But
line
the cumulative dose should not exceed 70 gray as a total.
exactly. Yes, exactly.
Any more questions? Okay. Thank you very much, Dr. Huda Arbouz, and we hope to see you soon in Egypt, inshallah. And we are very happy to have you in our 10th Ain Shams conference, and we hope to see you soon, inshallah. Thank you very much.
Thank you very much for inviting me. Thank you.